of Allah, the most merciful, the most beneficent. I welcome you all to our free webinar. It's nice to have our guest speaker again. I am Professor Dr. Dramirgilani, and I'm a consultant radiologist, and I work as Dean of Faculty of Allied Health Sciences at University of Lahore in Pakistan. I would like to introduce our speaker, who is Professor Dr. Richard Bees, who is BSc Honours, MRCP and FRCP. He is FRCR, sorry. He is consultant radiologist at Queen Elizabeth Hospital, London, in United Kingdom. He is also visiting professor at different colleges like King's College, London. And his topic today is an approach to the six most common pathologies. An approach to the six most common pathologies. So without wasting time, I will request our speaker to please start with your presentation. So Professor Dr. Richard Bees, please.
Thank you, Professor, and thank you for inviting me again to speak about the radiology of 5 to 6 common pathologies. Just to give you a little bit of background, I've been a radiologist for 20 years and teaching at King's College London, 5th year medical students, and also postgraduate radiology, FRCR. And I've learned more teaching than anything else. And once you start teaching, it makes you think about what you're saying, what you're doing and how you're doing it. And I've had more light bulb moments teaching. And it became quite apparent after 20 years of teaching that I was saying the same thing over and over again. And then I started looking at my practice, my medical practice in the West, and the cases that I was demonstrating were exactly the same cases. They were following the same pattern. And so I've tried to summarize them here today on this talk, the radiology of 5 to 6 common pathologies in the West. Now, I realize that these do vary around the world. I gave a talk recently on global health through the prism of ultrasound, and we went around the world looking at the uses of ultrasound, and what we saw was that the anatomy was the same, the environment changes and pathology changes. So I'm talking about really 5 common pathologies in my practice, and almost I could summarize 80 to 95% of my work in the NHS in these 5 common pathologies. And I've got to the point where I can actually summarize most of my work in 28 words. So let's go through these pathologies and see what I'm talking about. So first of all, we have to raise the question, what is radiology? Now, I used to be a clinician with a stethoscope. I was a medic, and then I moved into radiology. And it became quite clear it was definitely an examination. And it was examining what? If anybody can think what we're examining, if we had to summarize what we're examining with radiology, anybody, any thoughts? Well, we're really looking at the anatomy and the pathology, and the chest X-ray, which is pretty universal in radiology, is a very good example of this. So the anatomy of the chest X-ray, it's a 3-dimensional object on a 2-dimensional image. So we've got lots of overlying anatomy, and we can see here centrally the heart and mediastinum, then we have the lung fields, and overlying is the bone. So to be good at radiology, we have to be very good at radiological anatomy. Not only that, we have to be very good and understand our pathology. And this is where it becomes really key, understanding pathology, because it's the interaction of the anatomy and the pathology that gives us the image. But you have to have a really good basic understanding of pathology. And that's what I hope to reiterate today. And the pathologists are excellent because they don't use very many words when they're describing pathology. They keep it very simple. And if we can use pathological terms, then we can come up with some very sensible short differential diagnosis. So let's start with pathology number 1 that I see a lot of in radiology is fluid. So just to describe this chest X-ray, there's lost the silhouette sign of the left heart border, lost the silhouette sign of the left hemidiaphragm, and there's a new silhouette sign here with a meniscus, and this is in keeping with a pleural effusion. Now, fluid, does anybody know how pathologically we describe fluid in the body? There are 3 fluids. There's blood, which I'm not going to talk about, but then there's there is serous fluid, and we describe it in two ways, either transudate or exudate. So here we have on this chest X-ray a unilateral pleural effusion. The right hemidiaphragm and right lower zone are normal. So we have to then think, is it a transudate or exudate? Now, transudates and exudates are differentiated by the protein content, and exudates have a high protein content and generally indicate local pathology. This is a unilateral pleural effusion, most likely to be an exudate. And the two most common pathologies that cause a unilateral pleural effusion or exudate are infection and tumour. And I'll come to those pathologies in a second. So that's an exudate, most likely an exudate. So we would tap that, send it to the lab, check the protein content, check for cells, malignant cells, tumour cells, and we'd also send for microscopy, MCNS. And really, it's the lab that gives us the diagnosis. It's certainly the specific diagnosis. The radiology gives us a differential diagnosis, but it's still an awful lot more accurate than if you were just seeing the patient without imaging. So fluids transudate or exudate. Now, transudates generally are low protein content and generally mean a systemic problem. And here we have a case where you cannot see the silhouette of the heart at all, or the hemidiaphragms. We've got bilateral densities with menisci, with a new silhouette, air soft tissue interface, and these are bilateral pleural effusions, most likely to be a transudate, a systemic problem, low protein content. And the differential for this are all the failures, systemic problems, failures such as heart failure, renal failure, liver failure, low protein, low oncotic pressure, or hypoalbuminemia or low protein states. So let's go back to this. This is a local problem, exudate, high protein, infection and tumour. And then if it's bilateral, it's most likely to be systemic and a transudate. And we see a lot of fluid, and it's not just in the chest we see it. We can examine the pleural spaces with ultrasound, which is said to be the new stethoscope. It's a visual stethoscope, and it demonstrates fluid very, very well. It can differentiate, in this X-ray, it would differentiate, if we used ultrasound, between fluid, consolidation, and possibly tumour by imaging the chest. And let's be honest, it's the same anatomy, same pathology, but different imaging modality. Let's go forward. So fluid occurs pathologically in the body. On the left, we have a chest X-ray where the heart is enlarged, the cardiothoracic ratio is increased. We've done an echo, and it's a pericardial effusion. How could we describe a pericardial effusion diagnostically? Well, it's fluid, isn't it? So it's either a transudate or exudate. And if it's a transudate, we'll be thinking about systemic problems such as all the failures, heart failure, renal failure, liver failure, low oncotic pressure. Or if it's an exudate, it's exactly the same differential as in the chest. It's either infection or tumour. Again, we're repeating the same pathology. Now, if we go below the diaphragm, here's an ultrasound image of ascites. Here's the bowel, here's the dark, this is fluid, this is ascites, this is fluid again. And how could we describe this fluid pathologically? Well, it's either a transudate or exudate. And if it's a transudate, we'd be thinking about liver failure, a small shrunken liver, large spleen, we may find. We'd be thinking about renal failure or heart failure, and low oncotic pressure, exactly the same differential because it's fluid, it's low in protein, a systemic problem. If it's an exudate, again, the same differential. It's either infection or tumour. Now, we have a lot of I run a paediatric practice in Queen Elizabeth where I practice. We have limping children, and they come in and they have pain in their knee or hip and they limp. And we do an ultrasound, we find fluid in the hip joint. This fluid here. These are normally children over the age of 4, and they have painful walking. And we say there's a fluid in the hip joint. Now, what type of fluid could this be? Well, it's fluid again. Is it a transudate or exudate? And if it's a transudate, it's a transient synovitis. And if it's an exudate, which is what we fear, it could be infection or septic arthritis. Again, the differential for fluid is exactly the same. And radiology is excellent at demonstrating fluid. So let's just talk about the chest x-rays in front of us. Can anybody describe the middle chest x-ray, what type of shadowing this is in the chest x-ray? It's extremely common. Basically, the lungs on the chest x-ray are black, they're full of air, but these lungs have gone white. That means they're full of soft tissue density. Now, it could be soft tissue, but it's unlikely, it's most likely fluid. And this is a very interesting chest x-ray because what we see here is we've lost the silhouette sign of the left hemidiaphragm and the right hemidiaphragm. That means the pathology is adjacent to the hemidiaphragms. That means anatomically, the pathology has to be in the lower lobes. What we can clearly see are the heart borders. That means there's air adjacent to the heart. That means there's aeration seen in the right middle lobe on the right and the lingula on the left. So the pathology we can define as being in the lower lobes, probably extending into the upper lobes because it goes all the way along. So this is a density, it's uniform, and it's called airspace shadowing. And again, this is a fantastic name for the shadowing because it tells you that the pathology is in the air spaces. Now, the air spaces, does anybody know what the air spaces are? Well, they're alveoli. They're the alveoli. It's where the gas transmission occurs. And fluid, this is the density, is in the alveoli. Now, I've said before that if it's a systemic problem, the fluid is most likely to be a transudate. So we've got bilateral airspace shadowing in the lungs here, left and right. It's pretty uniform, and it's often seen with air bronchograms because it spares the major bronchi, and it's fluid in the air spaces. So it's bilaterally systemic. It's most likely to be a transudate. And the differential for a transudate in the air spaces is heart failure, renal failure, liver failure, exactly the same differential. And this would be a very good example of heart failure. Equally, it could actually be infection, but those are the most likely common systemic problems and failures. And this is a CT, which just shows how the lung has become solid. This is black, this is air, low attenuation. And you have these branching structures, which are the sparing of the bronchi, which are the air bronchograms you see on the chest x-ray. Again, it's the same pathology, same anatomy, different imaging. And here we have airspace shadowing surrounded by air in the bronchi. And this would be heard on the stethoscope as bronchial breathing. So is that, does that make some sense? We talk about fluid, we try and categorize it into transudate or exudate, or local or systemic or local. The differential the same for a transudate, the differential the same for an exudate, be it around the heart, around the hip, or in the abdomen. Again, it's fluid, the F word, it's transudate or exudate. And this is a really very common pathology, which radiology is excellent at demonstrating. Now let's talk about another very common pathology we see in the West, which is soft tissue masses or tumours. Here we have a chest x-ray of a 50-year-old smoker. And in the left upper zone, there's a silhouette of a soft tissue mass. It's about 6 centimetres, and there are no other findings. So it's a mass. Now, again, the pathologists describe masses in a very, very simple terms that everybody knows. A mass is either benign, malignant, and if it's malignant, it's primary or secondary. And again, that repeats itself over and over again throughout the whole of oncology. And the only way to get a tissue diagnosis is from a biopsy. So if you start talking about it could be this cell type, that cell type, you are guessing, because the only person who can tell us that is the histopathologist. So here we have a 50-year-old smoker with a solitary mass in the left upper zone. It's most likely to be within the chest, or it's in the lung, and it's most likely to be malignant. It's most likely to be a lung primary. And let's look at other soft tissue masses. So here we have a an MRI with a ring-enhancing lesion here in the left hemisphere with some surrounding edema. This is intraaxial. This is really important to describe in the brain, whether it's intraaxial or extraaxial, because the majority of intraaxial masses are malignant. The majority of extraaxial masses are benign. That's the majority. It's not always, but it's a good rule. And here we have a ring-enhancing mass. We've got breakdown of the blood-brain barrier. The differential for a ring-enhancing mass is either infection, but there's no evidence of infection in this case, or tumour. Now, the tumour can be benign or malignant, but we've said it's intraaxial, so it's most likely malignant. And then the differential is primary or secondary. Now, we can guess a cell type, but the only way to really know what the cell type is to do a biopsy. So if you start mentioning cell types when you're talking about radiology, you are guessing. Equally, if you're talking about certain bugs, very specific bugs like streptococci, again, you'll be guessing because only the microbiologists can tell us that diagnosis. Now, in the middle, we have an image of an MRI with a soft tissue mass behind the knee. Now, an orthopedic surgeon came into my office not long ago with such a case, a mass in the synovium behind the knee on MRI, and he wanted me to give him some information. Now, orthopedic surgeons are excellent at anatomy and pathology. So I said, I'm afraid it's a mass, it's either benign, malignant, primary or secondary. And he said, yes, we'll send it off to the specialist hospital for biopsy. That's all I could say about this. Now, I do know there are certain tumours that have certain characteristics, such as a synovioma or pigmented nodular villus adenoma, but it was neither of those. But because I just said, kept it very simple, benign, malignant, most likely malignant, primary or secondary, the next step is a biopsy. And of course, my mother had a breast mass, a lump in her breast, just like the mammogram here, but not quite like the mammogram here. And she woke up feeling it, and her first thought was, is this benign or malignant? That's what the patient is thinking when they feel a lump. Is this cancer or not? Is this benign or malignant? So just, again, this follows exactly the same rules of any soft tissue mass in the breast. Is it benign or malignant? And if it's a malignant, is it most likely to be primary or secondary? In this case, it's a spiculated mass within the breast here, and this is most likely to be a malignant primary. But all I'm talking about now is soft tissue masses. They're either benign, malignant, primary, or secondary. I sometimes ask the medical students, tell me about gallbladder tumours, and they look at me as if I'm talking from outer space. And I say, you know exactly how to talk about gallbladder tumours. And they look at me and say, well, we don't, sir. We don't know anything about gallbladder tumours. Well, you do, because they're either benign, malignant, primary, or secondary. And that's as far as the radiology can take you. There are certain tumours that have certain specific characteristics. There's no doubt about that. But the majority, you cannot tell what the cell type is. Only the histopathologists would do that, and that requires a biopsy. So that's my very second, very common pathology. This is a very common pathology, and this is infection. So on the right is a chest X-ray with airspace shadowing. Let me just get, if I can get my cursor. It's in the right mid-zone. There's air bronchograms. It's indistinct. It's airspace shadowing. Now we know that's airspace shadowing, so the pathology is in the airspaces. We know it's fluid. Well, it's unilateral. Is it systemic or local? Well, it's local because it's unilateral. It's most likely to be an exudate, high protein content. And in those airspaces are infective organisms. Now, I have to talk about infection all day long because I'm a radiologist, and radiology picks up infection. And I have to have a very simple understanding of microbiology. I have to give the clinician or whoever's referring the patient a very simple differential of infection. And my differential for infection, which I've used for 20 years and never let me down, and I was taught this when I was doing FRCR, is very simple. It's either bacterial, mycobacterial, viral, or fungal. And that is the differential for this appearance on this chest X-ray. This is most likely bacterial, and we give the patient antibiotics and repeat chest X-ray in 6 weeks' time. However, to get the microbiology, it has to either come out of the blood, as in a blood sample, blood cultures, or from the sputum. But the differential for infection on radiology is extremely simple. It's only 4 words, and that's bacterial, mycobacterial, viral, and fungal. And here we have again example of airspace shadowing of the air bronchogram. This is the airspace shadowing on the right here. It's very indistinct. It's not like the soft tissue masses with the silhouette. It just fades away. The air bronchogram. This is fluid in the air spaces. It's fluid in the alveoli. It's an exudate, and it's in keeping with infection. Very rarely, these can be tumours such as alveolar cell carcinoma. Here again, we have an area of consolidation, ill-defined, and look, it's lost the right heart border. So there's lots of silhouette at the right heart border. Now, I know anatomically, adjacent to the right heart is the right middle lobe. This means the pathology is in the right middle lobe. It's airspace shadowing. It is fluid. It's in the air spaces. Is it a transudate or exudate? Well, it's unilateral, most likely an exudate, and therefore most likely due to infection. And the differential for infection, my differential is bacterial, mycobacterial, viral, or fungal. I hope this is making some sense. Again, radiology is excellent for picking up certain types of infection, particularly when it forms a collection or an abscess. Clearly, radiology is negative in cases of such as septicemia where there is no foci, but often, sometimes there is a foci. And here we have an MRI of the spine, and here we have high signal within this disc on T2 weighted imaging with a collection here and a collection at the back. This is a case of discitis or infection of the disc. It will be affecting either side of the vertebral body, and the differential for this is infection, bacterial, mycobacterial, viral, or fungal, but most likely bacterial or mycobacterial. In the middle, we have a CT scan in the portal vein phase, and there's this abnormal mass in the right lobe, and it's got abnormal attenuation or enhancement. It's got low attenuation or lack of enhancement. The differential for this is tumor or an abscess. And we're talking about infection at the moment, so this is a liver abscess. And the differential for the liver abscess is either bacterial, mycobacterial, viral, or fungal. At the bottom here, we have an ultrasound of a focal lesion in the mid-pole of the right kidney, and again a CT, which shows it with an arrow. And this is of low attenuation, and abnormal enhancement on the CT, and low echo on the ultrasound. This is an abscess. The differential for this abscess microbiology is infection. It's obviously infection, but it's bacterial, mycobacterial, viral, or fungal. Again, just completely repeating this pathology, and it's very difficult to get it wrong if you use these broad terms. Let's just go back one. Now, the doctor came into me and said, "What do you think of this?" I said, "Oh, I think it's bacterial infection. I think it's pneumonia. I think it's airspace shadowing. It's in the right middle lobe." He said, "What type of bacterial infection could it be, doctor?" I said, "Well, it could be gram-negative, gram-positive. It could be community-acquired or hospital-acquired. It could be typical or atypical." And all of a sudden, I'm building a structure based on really very little information whatsoever, but I sound like I know what I'm talking about. And then he said, "Well, what type of bacteria could it be?" Well, I just gave him a list of things. It could be staphylococcal, streptococcal, it could be Staph aureus, it could be Klebsiella. You can't tell until you see the bug in the lab. Now, this is a very common pathology. This occurs in 1 in 3 people. And this is a patient with right leg swelling, swollen, reddened. We've done an ultrasound in the middle, and there's a filling defect in the vein. It's non-compressible. This is thrombus. And then the patient became breathless, and there's a CTPA here on the right, on my right, with filling defect in the pulmonary arteries. And this is a pulmonary embolus. This is thrombus. Now, most people, lay people, have at least 5 to 10 causes of thrombosis. They've heard it so many times. They know about aeroplane flights. They know about bed rest. They know about pregnancy. So as doctors, we've got to sound like we know what we're talking about. We've got to talk about the pathophysiology of thrombus. What is the pathophysiology of thrombus? Anybody got any ideas? We can't come out in an exam with a list of 20. We lose ourselves. So we have to have some sort of structure, and the pathologists have provided the structure. The causes of thrombosis. Well, it's Virchow's triad, and Virchow was a pathologist in the 1920s, and he said thrombus is caused by stasis, vessel wall damage, or increased coagulability of blood. And that accounts for all causes of and cases of thrombosis. Now, just to give you a quick story, I was at King's College, London, and I was asked to look at a case of portal vein thrombosis. It's a liver unit, and the portal vein is the vein that moves from the mesentery up to the liver, and there was thrombus in the portal vein. And I was a new registrar. I just started in the department, and really I was there slightly to be humiliated, really. However, I'd already done membership. I'd already done a lot of medicine. I'd got the membership exam, and I knew it was thrombus, and I said to the examiner, this is Virchow's triad: stasis, vessel wall damage, increased coagulability. And he said, well, how does that work? I said, well, this patient has got cirrhosis, so there is stasis, there's portal veins sludging and slowing, so that might cause thrombosis, and 10% of cirrhotic patients have portal vein thrombosis. Portal hypertension can cause vessel wall damage and calcification, and then said increased coagulability. They have big spleens, low platelets, and then there's causes of antithrombin 3, protein S deficiency, and protein C deficiency. Now, I didn't know anything about portal veins, and I certainly didn't know anything about the liver at the time, but because the thrombus word was used, I could apply Virchow's triad. I'm not saying that helped me, but 5 years later, they made me a consultant in that department. So it's about thinking on your feet. It's about thinking about thrombus, because thrombus occurs everywhere. And the biggest killers that are causing thrombus are these: stroke. So here we have high density in the MCA where the arrow is. This is thrombus in the middle cerebral artery, and the consequences are devastating. This is an arterial territory stroke involving the white and grey matter. This is thrombus. This is a stroke. This is a great cause of death and disability in the West. And equally, and Virchow's triad applies to this. Here we have thrombus in the left anterior descending, or atherosclerosis and thrombus. This is an acute MI. Here it is on CT. There is some perfusion distal to this, and here it is on angiogram. And again, this is thrombus again, and it's Virchow's triad: vessel wall damage from atherosclerosis, stasis from people not exercising or moving or being bedbound, hypercoagulability while smoking, that can cause platelet problems, and also all the prothrombotic causes that we've talked about: protein S, protein C, antithrombin 3 deficiency, and other things like hypercoagulability, such secondary to carcinomatosis or pregnancy. All of these can promote thrombosis. So thrombosis is really common, affects 1 in 3 people. The consequences are seen on radiology. The thrombus is seen on radiology. So we have to have a simple approach. How are we going to approach thrombosis? Because all the pathologies I'm talking about are incredibly common. They keep repeating you. If you have a structure to these, you sound like you know what you're talking about and sound like you studied radiology. So pathology number 4, degenerative disease. We see an awful lot of this in the West, in the UK. And here's the front of the British Medical Journal. And it states here in 1990, the red is degenerative disease, and how it's going to be in 2020. Well, it's going to overtake all the other causes of death and disability. Very common. And how do we see it? Well, we see degenerative joints. Here's normal knee space, the lateral and medial compartments, and here's loss of the joint space of the medial compartments, sclerosis, osteophytes. This joint doesn't work. Not only does it not work, it causes incredible amounts of pain and disability. These patients are quite lucky because they can have joints replaced. If you have a bad back and lose a joint space like here, you cannot replace the back. This can be incredibly painful and quite disabling. Patients can lose sleep because of the pain, and they lose sleep. They can become depressed, and when they become depressed, they can stop working. If you stop working, you cannot earn a living. If you can't earn a living, you can't sustain a family or a mortgage. It's a spiral of loss. It's absolutely devastating for these patients. Again, here we have a hip. There's a normal joint space on the left, and on the right, we've lost the joint space. We've got sclerosis, subchondral cysts, probably osteophytes. This is a degenerative, painful hip. These 2 joints can be replaced. This cannot. And we're seeing an increase in burden because of obesity and type 2 diabetes. We're seeing lots of degenerative joint disease. Some people say that heart disease is a degenerative problem, and there are lots of other degenerative problems that we can see on radiology. We see a lot of inflammation. This is a case of where we've got an interstitial pattern bilaterally, basally, with we have thickening of the lobar and interlobar septa with lines and nodules. The lines and nodules are just a reflection of the pathology, seeing these septa that are thickened. And this is a case of fibrosis, of which there is a differential, including idiopathic, drugs, connective tissue disorder, dust disease, and sarcoid. Inflammation, it can be systemic, as in this case, or it can be local, such as a joint. So let's just recap on the pathology. So fluid, transudate or exudate. Let's just, sorry about this, we're going to go back a little. Let's just remind ourselves, transudate or exudate for fluid, fluid around the heart, fluid in the abdomen, the peritoneal cavity, around the hip, in the pleural space. It's a transudate or exudate. And in the air spaces, transudate or exudate in the alveoli. Then we talked about soft tissue and tumour. All soft tissue is benign or malignant, primary or secondary. And as a radiologist, we see lumps everywhere. We ultrasound superficial lumps. We image them on CT, we image them on MRI, and they all pathologically classed as benign, malignant, primary or secondary. The patient hopes it's benign, and if it's malignant, we think about primary or secondary. Again, I showed you lots of different cases of soft tissue in the brain, behind the knee, and the breast, and then talked about infection, and that's viral. So bacterial, mycobacterial, viral, or fungal, that's my differential for infection. And we see that in the chest and also in the spine, the liver, well, virtually every organ. And again, it follows that differential. Thrombus, incredibly common. Talked about how it's a stroke and a heart attack, dural vein thrombosis, portal vein thrombosis. Thrombosis occurs everywhere. It's a very common, 1 in 3, can cause pulmonary emboli. And we talked about Virchow's triad, stasis, vessel wall damage, increased coagulability. Very easy to structure an answer in an exam if you have 3 stems of your differential. Very difficult to structure an answer in an exam if you've got 20 in your differential. And just very briefly, 2 weekends ago, I taught on the King's course, which is a postgraduate course for FRCR vivas. And I came across all bar 1 of my candidates were superbly wealthy in knowledge, but very poor in structure. So presentation, their differentials were too long, they were too chaotic, they were not ordered. And there was one chap from Egypt, a fellow at King's, and he had not only good knowledge, but he had good structure to all his answers. So there's thrombus, the consequences of. We talked about degenerative disease and how painful and disabling this is, and how it can stop people from functioning or working and earning a living, which is very distressing. And we talked about inflammation, local and systemic, and that is the summary of the pathology and my differentials. And that really is about 80 to 90% of my radiology practice. Of course, I see rare things, unusual things, but I can often categorize them into these 4 categories, plus degenerative disease, plus trauma. And here's my last question. Just to prove it's not all about the imaging, it isn't about the imaging, it's about patients. We image patients. I had this in my finals at medical school. 6 years I was at medical school, and I had this in my medical finals. So patient duplicans contracture. And I was allowed in my finals to ask 1 question that would make a difference to this patient. And I was 6 years at medical school, paid for by my father. My question was, how much do you drink? Now, clearly, that's not going to add anything to this patient's outcome. Does anybody know what the answer to this question is? You've got one question to ask this patient and it will change his possible outcome. Well, the question they were asking for is, how does it affect your life? So clearly, if this doesn't affect your life, they would do nothing. It would be medical management and physiotherapy. If, however, this affected your life badly, you couldn't work or you couldn't play the piano if you're a pianist, then they would offer a surgical intervention. That is just my final slide to show you that it's not just about imaging, it is about the patient. But imaging is extremely important in the diagnostics of patients. And although we're just a small cog in a big system, we do provide vital information to clinicians and patients. Thank you very much. And thank you for inviting me to talk on one of my favorite topics that I teach medical students and FRCR students in London. Thank you, Professor.
Thank you very much. Thank you, Professor Richard Bees. We have a couple of questions at the end. The first question is from someone from Sudan. He's asking that how can we do the differential diagnosis of infection on X-ray? Is it possible?
Well, it is possible. And if you give broad differentials, if you say it's bacterial, mycobacterial, viral or fungal, that's as far as you can go. You know there's an infective organism causing the pathological radiological changes, and in some instances they have characteristic appearances, such as hydatid in the liver. You will get membranes. You can almost certainly say that's a hydatid cyst. But in general, it's very difficult, and you have to give a broad differential, and it's only when you take a biopsy or a specimen and examine it in the laboratory can you be absolutely certain what type of organism you're dealing with. And clearly, not only do you get that information, but you often, the microbiologist will tell you what antimicrobials it's sensitive to. So I tend to steer clear of giving specific organisms. I keep it very broad to bacterial, mycobacterial, viral and fungal. And clearly a cavitating lesion at the apex in the lung is most likely to be TB. You can give probabilities, but you cannot be absolutely certain. The certainty comes through the microscope, both in the case of microbiology and histopathology. And it's very good to give broad differentials because it allows you then to talk about more specifics. If asked in vivas or by your colleagues, you can say, well, what type of bacteria? Well, as I said before, you can talk about gram positive, gram negative, aerobic, anaerobic. I don't know anything about microbiology, I'll be honest, but I sound like I do because I'm giving very sensible broad differentials.
Thank you. Another question from Ms. Maida Tahir. Does the cystic linear shadow on X-ray have any differential other than fibrosis?
It does what, sorry?
Does the cystic linear shadowing on X-ray have any differential other than fibrosis?
Cystic linear shadowing.
Yeah.
Well, let's just go. I don't quite know what cystic means. You can, obviously get lung cysts and cystic lung disease, and there are 4 general differentials of cystic lung disease, from neurofibromatosis, tuberous sclerosis, etc. But so can emphysema, etc. So, and the lines and nodules generally mean an interstitial process. And in this, as you know, hopefully you all know, that the interstitium is a connective tissue that holds the lung together. And you get thickening of the lymphatics and the interstitium or the connective tissue, and that's typical of an interstitial process, which is a completely different process to airspace shadowing, where the pathology is actually in the alveoli. I don't know whether that answers the question, but
I think she was asking about cystic fibrosis of lungs.
Oh, well, cystic. Yes, sorry. Tell me, Professor. Go on.
Yeah, she's asking about cystic fibrosis disease of lung, and she want to know any other differential diagnosis if it looks like fibrosis. But what are the other diseases we can suspect?
Right. Well, cystic fibrosis is bronchiectasis. It's a congenital bronchiectasis, and it involves both lungs and generally all zones. And radiologically, that's characterized, I haven't got an image here, of ring shadows and tram lines. And all they are is non-tapering bronchi seen on the radiograph, either end on or from the side. And generally the differential, if you see widespread bronchiectasis, particularly in a child or a young adult, it generally means there's a systemic problem. And the differential for by far the commonest cause is cystic fibrosis. But there are other things that cause a generalized bronchiectasis. If you know the exams and you do the exams, I heard this on 2 weeks ago when I did the King's course, and I have an example of this. So the differential for cystic fibrosis is something like cardiac syndrome, where you get dextrocardia and also bronchiectasis. Widespread infection, such as TB or whooping cough, can give you bronchiectasis, but that tends to be more focal. And the other things are immune compromises states, such as hypergammaglobulinemia or thymic aplasia and Dye-George syndrome. That's generally the accepted differential for widespread bronchiectasis. But by far the commonest cause is this autosomal recessive cystic fibrosis. So I hope that answers the question. Again,
thank you very much.
Yeah.
The last question is from a friend from Bangladesh. He's asking that how can we differentiate between a thrombosed pulmonary vessel and a mass?
Well, yes. Well, they're two different entirely pathologies. So a thrombosed vessel is a filling defect in a contrast-filled vessel. So it's actually one of the key things about radiology is where is the pathology? Is it in the lung fields? Is it in the pleura? Is it in the bone? Is it in the blood vessel? So you will see within the blood vessel a filling defect surrounded by contrast, and that is thrombosis. Now, if you're looking at a mass, they generally originate from the lung and not from the blood vessel. So you'll see it originating from the lung parenchyma. Malignant processes, particularly in the lung, they can invade the blood vessels, they can compromise the blood vessels, they can nip off the pulmonary arteries, they can actually provoke thrombosis, but you can definitely tell on imaging, be it axial imaging, particularly axial imaging, the difference between thrombosis and tumour.
Thank you very much. Another question just arrived is that for degenerative disease, X-ray is the modality of choice, or we need any other modality of radiology for diagnosis of degenerative diseases?
Well, degenerative diseases are very common, but the plain X-ray is probably the best to demonstrate the joint problems. I mean, that's degenerative joint disease. We use the X-ray looking at shoulders, knees, and hips and backs. But there are other degenerative diseases which are associated with type 2 diabetes, such as heart disease is said to be, and there you would use CT or angiography, really. But it depends what type of degenerative disease you're looking for. Degenerative brain disease, such as dementia, would be using CT and MRI. And degenerative disease is really accelerated aging. So you've got a part of the body that's worn out earlier than other parts of the body, and it's an indicator of poor health, unfortunately. But it's extremely common, certainly in my practice.
Yes, thank you very much. We have another question from Sudan. There is an attendee named Maha Al-Zubair. What causes the lung cavitation?
Well, lung cavitation, that is a very good exam question. So I have cavitating lung lesions in my collection because the differential is very short. So a solitary cavitating lesion of a reasonable size, the differential is infection, tumour, and infarction. And of the types of infection, it's bacterial, mycobacterial, viral, or fungal. And the types of tumour, well, it's benign or malignant, generally not benign, either primary or secondary. If you see multiple cavitating lesions, Then you think about connective tissue disorders such as, or vasculitis such as vagus or septic emboli. So it's a great exam case because actually it differentiates people who certainly know their pathology and who can articulate the pathology in a sensible way. And I did this course a couple of weeks ago, and I have some very standard X-rays in my collection that I show them. They're level 1s. You have to get these. You have to do well on them, because if you don't do well on the level 1 standard X-rays for diagnosis, then alarm bells ring with the examiner. And one of the candidates said, "Oh, I really enjoyed your cases. They were quite easy." I said, "Well, if they were so easy, why didn't you get 8 out of 8?" Which you didn't. And so we put these very standard X-rays in our teaching formal packets, because I can differentiate a good candidate from a bad candidate by just a pleural effusion. I know the candidates are desperate to see really rare things and be challenged, but the FRCR exam certainly is not about rarity. It's about doing the standard very well, the common things very well. And that's what we're looking for. It's all about safety.
Thank you very much. With this, we have finished this webinar. Thank you very much, Dr. Richard Bees, for your time, for your nice presentation, for sharing your experience and expertise. I'm thankful to all the attendees of our team of Afro-Asian Institute of Medical Sciences. This recording will be live within 1 or 2 days at our YouTube channel of Afro-Asian Institute of Medical Sciences. And it was live streaming on Facebook. We have some other courses which are coming up. Next week, we will also have a lecture from our Australian friend who is an international expert in nursing. And we hope to see Dr. Richard Bees again. He will be having some other seminars in future, and he's going to conduct a 4 weeks online course on ultrasonography, which will be starting next month. For those who are new, they can visit our website at www.aims.edu.pk. So with this, we thank you all. Thank you, Professor, for your time. Thanks again.
Professor, thank you very much to you and your team. Excellent. I'm very pleased.
Welcome, sir. Welcome. Have a good evening, sir. Bye-bye.
Bye-bye, sir. Thank you.